Thank you. It's a pleasure to be here this afternoon. Anyone in this room who's involved with clinical medicine recognizes that back pain is very common. This is the bone and joint decade as put forth by the U.S. federal government, and that entity, that task force, produced a book just this year called The Burden of Musculoskeletal Disease in the U.S. And statistics from the most recent year of 2004 prove forth that indeed back pain is very common. It's the most common physical condition requiring medical care. It's the most common physical condition that affects function and causes disability, and is a leading cause of medical visits to practitioners' offices. In fact, 12 to 15% of the U.S. population sought out medical care for back pain in 2004, and that equated to approximately 45 million patient visits. We all hear about the cost burden of back pain, and this number has been increasing over the years. So in 2004, again, the work from this Bone and Joint Decade Task Force shows that direct medical expenses of $90 billion, indirect medical expenses, which include things such as lost wages or disability payments, $20 billion, total costs in 2004, $110 billion. Where is some of this money being spent? Well, some of the money is being spent for surgery. In the U.S. in 2004, there were approximately 1 million spine surgeries performed. The breakdown is roughly what you see here. Discectomies accounted for 325,000 surgeries, about 34%. Fusions, 308,000. Decompressive surgeries, 160,000. Revision fusions, 19,000, and a few other scattered surgeries. If we break down lumbar fusions a little bit further, we see that for the period of 1959 to 1990, so a 31-year period, there was a 55% increase in the rate of spinal fusion. In the period 1990 to 2003, approximately a 13-year period, there was a 250% increase in the rate of lumbar fusion. Now, there's many factors to account for that. Certainly, we've had advances in technology, including devices and techniques. There's been market pressures, in part from some of the device manufacturing companies, and we won't need to spend too much time discussing that this afternoon. Patient culture has changed. Patients have become more consumers and are more demanding about looking for that fix for their back pain. And we've learned more in terms of the science of what causes back pain. But the question remains, has the pathology really worsened? And it's not surgery alone that's increased the costs. There's a presentation by a woman, Jana Freely, a physician who's in the Department of Rehabilitation Medicine. She presented this recently at the Association of Academic Physiatrists in California. Between 1995 and 2005, the use of epidural steroid injections increased by over 4-fold. This accounted only for patients who were in the Medicare age group, 65 and older, as well as procedures done only in ambulatory surgery centers. So clearly this number underestimates the amount of injections that were performed. If we look at the reimbursement for lumbar injections, in 1995, the professional fees were approximately $7 million. In 2005, those fees increased to $97 million. So with all this increase in treatment, have we actually improved patients' lives? A recent study in JAMA this year, again by a number of practitioners and researchers from the University of Washington, suggested that for age and gender adjusted self-reported measures of physical function, that in fact there's been less function over time. In 1997, nearly 21% of people described some impairment in their function. In 2005, nearly 25% of people stated some impairment in their function. So clearly, despite all this improvement in techniques, increased surgeries, increased injections, and other care, I'm not sure that we're actually improving patients' function. The bigger question is, how do we maximize outcomes? Well, proper patient selection is probably number one, and that involves a multidisciplinary approach. And I will say to you that probably the most rewarding aspect of my day-to-day treatment of patients is that I can walk down the hall to my orthopedic or neurosurgical colleagues and actually talk to them face-to-face, bring them into the patient's room, and have a very thoughtful and intense discussion about patient's care with the patient present. And that way we can share ideas and share information. Patients really like that, plus I think it gives us the best opportunity to provide the best care for patients. Ultimately, we want to match the treatment to fit the patient's needs, whether it be non-surgical, surgical, or pain management. As practitioners, we have to recognize our strengths as well as our limitations, and we know the saying, if all you have is a hammer, everything else looks like a nail. So with that, I'm going to turn the program over to the speakers. Thank you.
Thank you. Well, we wanted to start this first talk echoing what Dr. Weinstein said and putting it together in a multidisciplinary approach. So we're going to split up this first talk between the three of us. It's kind of an example of how we like to run our clinic and see our patients in a multidisciplinary approach with the three of us interacting, talking about patients, and figuring out what's right for them. So first of all, the assessment. Main thing, rule out bad things. You want to make sure you rule out the emergent things, the things that can cause serious injury, first and foremost. You want to establish a diagnosis and also understand the scope of the problem. So you want to look at patients' pain, their disability, and also, very important, are psychosocial barriers. The assessment can also be used to educate patients and to initiate the treatment plan. So as we go through the history, the way that I like to teach the residents is with a simple mnemonic, OPQRST, so onset, pattern, quality, radiation, severity, and time, and we'll go through these. So the onset, was there trauma? Was it an insidious onset? Looking at trauma, so major trauma in young patients and even minor trauma in older patients, especially those with osteopenia, osteoporosis can cause a fracture. So it's important to know if there's a trauma history. Probably going to direct your physical exam and your imaging studies differently. So looking at the pattern, what makes it better, what makes it worse, what's the quality, sharp, stabbing, aching, dull, burning. And a lot of times a drawing such as this one can be helpful. That way the patients can mark down exactly where it is. It makes them think about where their symptoms are specifically, and it helps you to tailor things as well. Radiation, does it radiate in a radicular pattern? Is it in a peripheral nerve pattern? Does the radiation not quite make sense in an anatomic way? So severity, we all are pretty used to using the visual analog scale, so 0 to 10. I also ask patients, what's your pain level at the worst? What's it at its best? What is it in clinic today? What's the worst it's been in the past week? It helps to get an idea of what the range of symptoms are. If they tell you it's a 10 out of 10, a lot of times that's the worst. But what is it normally? And then time, the duration of symptoms, are they overall getting better, worse, staying the same? And do they have a history of previous low back pain? So what are the red flags? What do we need to make sure that we look out for? Well, cauda equina, true medical emergency. What you want to ask about, loss of bowel or bladder control, severe progressive neurologic deficit, worsening weakness, sensory loss, especially saddle anesthesia. Look for loss of reflexes. And then a question that we often fail to ask is about sexual dysfunction. Something changed recently. The new onset of sexual dysfunction can also be another tip-off. And you can have cauda equina with or without pain. So just because they don't have pain doesn't necessarily mean they don't have this serious problem. Additional concerns are tumor or infection. So ask about constitutional symptoms, fever, chills, etc. Is the pain awaken them at night? Have they had weight changes? A history of cancer too, especially breast cancer, lung cancer, is something that you want to ask about. Might tip you off that you need to think about tumor. IV drug use, and then patients who are immunosuppressed or have been on corticosteroids long term. Another question is what they've done in the past treatment-wise and what's worked. We don't want to recreate the wheel. And we also want to know what has worked in the past. So I always ask about oral medications, physical therapy, and as we all know, not all physical therapy is created equal, and not all patients do their home exercise program. So just because they said, well, I did physical therapy, I've already done that, it didn't work, I think we need to dig a little deeper. Well, what did you do? Did you do the home exercises? Did you go on an ongoing basis? And I think it's important to dig a little bit deeper into that. Ask about massage therapy, chiropractic, acupuncture, injections. Did they have epidural injections, peripheral joint injections? Did that work? Where did they have them done? And then, obviously, a previous history of surgery is important to note as well. To those of you who are in primary care, I think we can't ignore the psychosocial aspects of this too. Ask about mood, depression, anxiety, hopelessness, frustration. Could be prior to the pain, could be because of the pain as well. How the pain affects their relationships, their mood. And a poor mood can be associated with as a bad predictor for disability too. So Winston Churchill once said, "True genius resides in the capacity for evaluation of uncertain, hazardous, and conflicting information." So I think taking a really good history is really important and can be helpful. So physical examination. So just taking a quick step back, and I won't bore you with too much biomechanics, but when we're looking at flexion, so looking at the disc, the nucleus moves posteriorly. The facets, the inferior process moves up and anterior, the neural canal widens, and ligaments limit flexion. So depending on if flexion hurts more or extension, you can think about what structures are being stressed or relaxed, can help you to figure out exactly where their pain is coming from as well. In extension, the nucleus moves anteriorly, the facets are more interlocked, the neural canal narrows, and the bones and joints limit extension more. So the physical exam should include evaluation of the neurologic, vascular, and musculoskeletal symptoms. It's usually composed of inspection, palpation, range of motion, flexibility, functional neurologic assessment, and provocative maneuvers. And this may be review for some of you, but since we have such a wide variety of practitioners in the audience, we'll go through this and include some of the data to support the findings as well. So on inspection, observe the patient during the history portion too. Sometimes patients, you'll see some pain behaviors, you'll see they're standing, they're kind of sitting sideways on their chair. It gives you a pretty good tip-off as to how they're feeling while they're distracted and telling you about their history. I saw a case at our academy meeting last year with a patient that the resident hadn't disrobed and ended up having a rather large rash over their backside. And we've all heard stories about that. I think it's still really true, and it's important. Have them disrobe, make sure that you're looking at their skin and not just examining them through their clothing. Body habitus is important to note. Posture, and I look at posture sitting, standing, and while they're ambulating. And this doesn't have to take very long. You can watch them as they're getting up from the chair to the table and while they're standing up. So it doesn't have to be specifically that you're making them walk across the room. It might be, but you can incorporate it into the rest of your exam. Look for muscle bulk and atrophy, and then rashes, erythema. Look at their skin. I think it's important to look from front, back, and from the side. Look at their head position, shoulders, look for scoliosis. Just look for general posture. All right, so palpation. With them standing, I generally start looking at their iliac crests, looking for symmetry. The iliac crests, just to remind everybody, are right about the level of L4. And then palpate their spinous processes. A step off might tip you off that they have a spondylolisthesis. Prone, you can palpate the paraspinal and gluteal musculature, looking for tender trigger points. If you palpate their posterior superior iliac spine, or the Fort and finger test, might be useful to diagnose sacroiliac joint pain. Palpate their greater trochanters, the ischial tuberosities, and their spinous processes. And then the poor man's discogram. I don't know who actually named it that. I've heard it, but I haven't seen it actually documented. When you have somebody prone, PA pressure right over their disc can increase the pressure in the disc. It's not sensitive or specific, but again, in the whole grand scheme of things, might give you a little bit more information. And then obviously look at their lower extremities. When we're doing vascular, palpate for distal pulses, look for edema, and then findings consistent with peripheral vascular disease. Range of motion can be done both passively and actively, flexion, extension, side bending, and rotation. I think most important is big limitations, side-to-side asymmetry. And there was, in the past, it's been shown that that range of motion may be affected by age and sex, but that occupation and BMI generally do not independently affect range of motion. I'm not going to go through this whole thing. Why I put this up here was to look at flexion at L3-4 and 4-5. So there's the greatest amount of flexion at these two levels. So when you're thinking about herniated disc, things like that, you can think about the pathophysiology and why that is. You have the greatest amount of flexion at those regions. Just reviewing Thomas test to look for hip flexor, contractures or decreased range of motion, check the hips for internal, external rotation. Also look at the knees and the ankles and the hamstrings. So just a quick thing about ligamentous laxity. Especially in younger folks, we know that ligamentous laxity is great for gymnasts, ballerinas, but can set people up for further musculoskeletal injuries down the road. So manual muscle testing. You want to evaluate the different peripheral nerves and the nerve roots. So hip flexors, quads, tibialis anterior, EHL, gastrocs. And then I also look at hip abductors. You can have them stand on one leg and look for a Trendelenburg, or you can also do side lying, which is not functional, but still if you can isolate their hip abductors, you can test those side lying. Sensory exam, looking at true dermatomal sensory changes versus that stocking glove distribution that's consistent with peripheral neuropathy. You can also test vibration, proprioception, pinprick. And then reflexes. So people generally know the quads are L4 and the ankle reflex is S1. There is actually a reflex to test L5, which is the medial hamstrings. And for those of us who have some trouble sometimes getting reflexes, there's this technique described by Jendrasic, where he has patients hook their fingers together and pull them apart as strongly as possible, and then tap the reflex. It distracts people and sometimes gets them to relax so you can actually elicit a reflex. So we'll quickly go through the provocative maneuvers. And I did include some data on these, which you'll see is not as solid as maybe we've thought in the past. So straight leg raised, the theory behind it is that you're stretching the nerve root and evoking pain. It's positive when the supine leg is elevated to between 30 and 70 degrees, and pain is reproduced down the posterior thigh and below the knee. So pain that is produced when you lift the leg less than 30 degrees or over 70 degrees is not considered to be related to nerve root irritation. Sensitivity, 91%, specificity, 26%. So very sensitive, but not very specific. So the cross straight leg raise is pretty much the opposite. So the theory is that if you are pulling laterally on the dural sac with the other leg, that you're still increasing tension on the affected side. So it's positive when the contralateral leg is elevated and pain is reproduced, just as it was in the straight leg raise. So this is actually the opposite, not very sensitive, but very specific. And just to remind you, the straight leg raise sensitivity and specificity. So slump test, I've actually seen this documented several different ways. The subject basically sits with the arms behind their back and their legs together. Same theory as the straight leg raise, increasing dural tension. So the patient slumps forward as much as possible, add neck flexion, extend the knee, and you can add dorsiflexion of the ankle as well. And it's positive if pain in the leg is reproduced. I've heard different descriptions where then people say, well, if you lift up the leg and reduce the dural tension and the pain is resolved, then that's positive. No data on reliability or validity. Braggart sign is just increasing ankle dorsiflexion to increase the dural tension, to increase that stretch. And it's actually been found that it was positive in over 90% of patients with a disc herniation, 78% positive in patients with a bulging disc, but it was positive in 75% of people that had negative findings. Femoral nerve stretch test, same idea as with the straight leg raise. In the slump test, you're increasing dural tension. This time, it's on the front side of the leg. So you have patients prone, you bend their knee and see if their pain anteriorly is reproduced. And this has been found to be positive in about 90% of patients with a high lumbar disc herniation. So set loading, so what you're trying to do is increase the pressure on the facet joints. You have patients extend and rotate. It's positive if it reproduces the symptoms. Unfortunately, there are no data specific about sensitivity and specificity. Faber and Faders. So Faber's or Patrick's test is used to assess hip or SI joint dysfunction, and then Fader is used to assess problems with the lumbar spine. And again, unfortunately, there aren't any data on the reliability of these tests. And the spring test is you have a patient prone and you have downward pressure applied to the spinous processes to determine either hypomobility or hypermobility of each specific level. And unfortunately, again, there are no data about this. So just really quickly, I think whenever we're talking about physical exam for patients with low back pain, people always ask about Waddell's signs. And I think it's important to remember that this is not used to determine if patients are malingering. I think it should be used as a tip-off that maybe you need to consider other factors, the psychosocial implications associated. But again, it is not a diagnostic tool to say that the patient is malingering. Greater than 3 out of 5 is considered clinically significant and correlated with significant psychosocial overlay. So distraction, so the findings are present when you specifically examine a patient, but they're not there when the patient's distracted. So for example, you could do the slump test and have the patient in the same position while testing strength, see if one's positive and one's not. Overreaction, just disproportionate expression of symptoms that don't correlate with your physical exam. Regional disturbances, so widespread region of symptoms that don't follow any certain anatomic pattern. So the fourth one is simulation test. So you give the patient the impression that a particular exam is being carried out while actually there isn't a specific anatomic reason for what you're doing. So for example, trunk rotation, you can do axial load by just pushing on the top of their head, and again, those shouldn't cause any, there's no anatomic reason that they should be causing low back pain. And then tenderness, so extreme tenderness, either to superficial touch or non-anatomic tenderness. I think another thing to consider when we're talking about physical exam is the functional evaluation. So we can do each of these little examination maneuvers, but how does the patient function? How do they do a single leg squat? What's their abdominal strength like? What's their lumbar extension strength? I think these are also important things to consider. And I'll turn it over to the next speaker.
Thanks, Marla. So Marla spoke about history and physical and the approach to low back pain. I'm going to focus my portion of the talk on imaging regarding low back pain. So in this talk, I'll speak on imaging options, imaging timing, and also interpretation of the imaging, which is very important. There's obviously a lot of different ways we can image the lumbar spine, and I'm going to focus primarily on the basic X-ray and also the advanced imaging of a CAT scan or an MRI, also including a CT myelogram. Now, X-rays are usually the first line of imaging that I use when I evaluate a patient with low back pain. You know, X-rays can often be poo-pooed as, well, it doesn't give us a lot of information. You can't see the disc on an X-ray. You can't see soft tissue. Why bother getting an X-ray? And I actually have to disagree. I think you can get a lot of information on these X-rays. Going back to my junior orthopedic resident days, every time I look at an X-ray, I always think of the ABCs. So I think of alignment, A for alignment, and I look at the alignment of the spine overall. You can see on this AP, it's fairly straight. You see on this lateral, we see the nice curve here, a nice amount of lumbar lordosis, a normal amount. We see that the posterior vertebral wall here, they're supposed to be relatively collinear, and in this normal patient, they are. And B for bone, we look at the bone quality, we look for any fractures or any abnormalities in bone. C, you think of cartilage, or discs, or D for disc space. You can't really see cartilage in the lumbar spine because the cartilage would be right here. With the disc space, we can't see the discs, but we can see that the space that they represent, so we can see if there's decreased height, which should be indicative of degenerative disc disease. This is a lateral X-ray, and here we can see there's a lack of alignment. We see what we call spondylolisthesis. Spondylolisthesis is when there's a slip of one vertebrae on the other. If you follow our posterior vertebral line here, we can follow these lines that are relatively collinear until we get down to the L5-S1 junction. And there's a step off here. So this is an obvious abnormality that we pick up on a basic lateral X-ray. And this abnormality is because of a pars defect that we can see here, but we can also better see on different X-rays. Fracture. We can see fractures on X-rays too. This is an example of an osteoporotic compression fracture. Here, this is an example of a normal vertebra. You see it's fairly box-like. The end plates are fairly straight. This is an example of an osteoporotic compression fracture. You can see that the height is slightly decreased. It's not quite symmetric and has a wedge-like appearance. This is easily visualized on standard X-rays. Scoliosis, as I mentioned before, in the AP view, the spine is supposed to be straight up and down. You can see in this poor patient here, she has a a large curve is actually shifted to the right. If you look closely, you can see that this L3 vertebrae is actually slipping off this L4 vertebrae. It's almost falling off completely. Again, can be easily picked up with plain x-rays. And kyphosis, which is a hunched over deformity, we can view this on the lateral film as well. Again, this is our normal lumbar lordosis, and you can see this patient has lordosis here in the lower lumbar spine, but then she starts to bend forward higher up, and this is indicative of kyphosis. Now that's basic AP and lateral x-ray. There are special x-rays we can get like obliques and flexion extensions. Usually I don't get these routinely as a screening x-ray. I usually get these if I suspect that there's a specific problem that I want to address. This kind of takes us back to our first year of medical school in terms of anatomy, the old Scotty dog. If you can look here, this is the eye or the face of the Scotty dog. This is the snout here, which represents the transverse process. This is the superior facet, which is the ear. If you go down here, there's the inferior facet, which is the front paw. There's the back paw, which is the spinous process. And this is the lamina. So we have what we call a Scotty dog. You can see this is true at every single level. And when we get down here, you can see that the neck of this poor Scotty dog is broken, which is indicative of spondylolysis or a pars defect. This is an oblique view of the x-ray, which we commonly get in kids who have a lot of back pain. This is a syndrome we commonly see in kids who engage in a lot of hyperextension exercises or repetitive extension, like gymnasts or football players. Flexion extension views. We get lateral x-rays with the patient bending forward and the patient bending backwards. And the reason why we do this is sometimes the motion will accentuate some pathological motion. Here we see on L4 and L5, there's actually a little bit of step off here. I would call it a grade 1 step off. And this we can see because the patient's bending so far forward, they're actually accentuating the pathology. Again, I wouldn't obtain these flexion extension or oblique views on a routine basis, but only if I felt that they were indicated. So moving on to CAT scan. Well, CAT scan gives us a lot more definition and detail regarding bony anatomy. Here we can see on this axial cut, we can see the vertebral body and the associated pedicles. And a CAT scan is a wonderful tool for preoperative planning. If we're planning on putting a screw in a certain spot, we want to make sure we have enough bone to do so. It's a wonderful tool for giving us more information regarding fracture patterns. Here on this X-ray or CT to the right, you can see the fracture pattern, see a little piece of bone actually going into the spinal canal. It's not usually used as a routine screening test, and I usually don't obtain this initially. I usually get it if I need to perform preoperative planning or if I want to evaluate the bony anatomy in more detail. A CT myelogram is a CAT scan with a contrast injection into the spinal canal. With this contrast, we can follow the shadow of the spinal sac, and we can actually see areas where the spinal sac is being kinked off or being pinched. This gives us an idea of where the neurological compression is. You can see in this patient here, this patient actually has a spondylolisthesis at this level. We can see that the dye signal is cut off here, which suggests to us that the nerve is being compressed in this area. In addition to seeing obvious compression, we can also see soft tissue anatomy. You can see these are bulging discs here, which aren't providing a whole lot of compression, but we can get a good idea of soft tissue anatomy with a CT myelogram. The big drawback with a CT myelogram is that it involves an injection, which is relatively low risk, but still invasive. An MRI is really the workhorse for evaluation of lumbar problems. This is a sagittal and a cross-sectional view of a normal MRI. MRI is useful for looking at soft tissue anatomy, where X-rays are good for looking at CAT scan, or X-rays are good looking for bones, and CAT scans are good at looking at bones in detail. MRI is good for soft tissue, so we actually do see the disc on an MRI, and we do see the spinal cord and other details. This here is your spinal cord here, and the spinal cord is like a giant tassel. It's cord-like up here, but then it becomes divides up into several different nerve roots and rootlets here. You can see our bones pretty clearly here. We can see our disc spaces here as well. This white signal here is all CSF, or cerebral spinal fluid. On a T2 weighted image, water is white, so we can see the amount of fluid around the spinal cord or the neural elements. On this axial cut here, you can see the spinal sac here, all this white signal. You can actually see the individual nerve rootlets down here. So this is an example of a normal MRI. As I stated, MRI is excellent for looking at soft tissue anatomy, like a herniated disc. Here we see at the L4-5 junction, we can see there's a herniated disc right in this region here. And on the axial cut, if we follow the tracing of the disc, we can see that it's actually herniated to the patient's right side. This is, this is a traversing nerve root here, which we can see in its entirety, but we can't really see this one very well because the disc is abutting right up against it. And this is really the strength of the MRI. In addition, we can also see tumors on MRI. We can see intradural tumors, and we can also see metastatic disease. This isn't the lumbar spine, but it gives us an idea of tumor involvement of the spine. Also, MRI can show us degenerative disc disease. So on a T2 image, the discs are supposed to be pretty well hydrated. They're supposed to have a good amount of water in them. We can see at these discs here, L2, 3, and 3, 4, these are white because they're well hydrated. At L4, 5, and 5, 1, these discs are dark because they're not quite as well hydrated, and they give a darker signal on the MRI. Technically, it's not a normal MRI, and these discs are degenerative or considered to be abnormal. But we have to be cautious in how we interpret the MRI. The MRI is a fantastic imaging modality, but sometimes it can be too sensitive. In a study by Bowden and JBJS, what they did is they looked at 100 asymptomatic patients and got MRIs in all of them. And they looked at the MRIs and looked for any abnormalities. In the age group less than 40, 25% of people had abnormal MRIs, degenerative discs, bulging discs, annular tears. But it's important to remember that these patients were all asymptomatic. In the age group over 40, 60% of these people had abnormal findings on their MRI. So just because someone has an abnormal MRI doesn't necessarily mean that that's responsible for their pain. They may not be having any pain, and their pain may not be related to that abnormality seen on an MRI. So as clinicians, we have to be cautious in how we correlate our advanced imaging findings to our clinical findings. And this, I can't stress this enough. Oftentimes we'll see a radiology report which lists every single abnormality, and patients sometimes get fixated on bulging discs or dark discs, and they're convinced it's a source of their pain. As clinicians, we have to, number one, decide if that is a source of pain and be able to treat it accurately. So this is a big issue in imaging of the lumbar spine. So timing. Well, low back pain, as Dr. Weinstein said, is pretty common. How many people in this room have had low back pain? I know I have. And the key thing to remember that it is so common, and most of the time it does resolve with pain, and most of the time it does resolve with time, pardon me, and non-operative treatment. In fact, first-time occurrences of back pain, 90% of the time it'll resolve within a month's period of time. So keeping that in mind, we don't necessarily want to order all these tests when someone comes in with a first-time occurrence of back pain. I think it's pretty reasonable to order a standard AP and lateral x-ray of the lumbar spine if someone is complaining of enough back pain that they're seeking medical attention. But it's not necessarily appropriate to get an MRI right off the bat. When do I get an MRI? Well, I get an MRI if someone has severe neurological deficits, if they have symptoms of neurogenic claudication, if they fail non-operative treatment and they're having persistent pain or worsening pain. But in general, I try all these people with a solid trial of non-operative treatment prior to going to advanced imaging. When do I get a CT myelogram or a CT? Usually I get this if an MRI is contraindicated. A CT myelogram will give us good information regarding neurological anatomy. But again, it is invasive, and I prefer the MRI over that. That's just my personal preference. Many surgeons will go right to a CT myelogram before going to an MRI, and it's sort of a dealer's choice in that regard. But the CT myelogram is a good alternative if an MRI is contraindicated, if the patient has a pacemaker or metal clips or for any other reason. And finally, CT sometimes we use as a preoperative tool to evaluate bony structures. And that's pretty much it for basic imaging for low back pain.
That was a great talk, Mike and Marla. I'm glad to be here speaking with you guys this afternoon, and the topic of my talk is to continue the basic approach to low back pain and talk about the emergencies and the differential diagnosis. Now that you've learned how to take a history and how to read x-rays and MRIs and CTs, I'm sure this part of the discussion will be pretty simple for you. So we'll jump right into it. Just some basic anatomy. You know, the spinal alignment is important for us to look at. There are several curvatures we always mention when examining a patient. In the lumbar spine, there's this lordosis. In the thoracic spine, there's a slight kyphosis, this bend forward. And then you reinitiate sort of the normal alignment and the positioning of the head by having a cervical lordosis. And overall, in terms of alignment, your head should pretty much sit in the middle of your pelvis, and also in terms of balance on the side view, you should also have the head sit pretty much in front of what we call the S1 or the sacrum. The other anatomy we want to mention is that the spinal column serves as a sort of a protection for the neuroelements. Since I'm a neurosurgeon, I think that's very important. So here's a cross-section of what the bony structures look like and what the neuroelements inside that it protects. Here's the vertebral body. Behind you have the spinous process that you can palpate from somebody's back. The lamina and comes down on both sides. There's a left and a right side. And the space that it creates with the vertebral body in front and the lamina and spinous process in the back is the canal space where the spinal cord runs through at the upper level. Then the cord ends at the conus, usually at L1, 2, and then the nerve roots are running through the canal. And then out the little side is the foramen where the nerve exits. So there's different type of impingement I'll talk about in our later slides, which is spinal canal space narrowing as well as this foraminal space narrowing where the nerves exit. And the spinal ligaments are important in terms of what can go wrong and what can cause low back pain as well. Usually these ligaments and flavum is a band sheet of tough fibrous tissue that connects the bone, cartilage, and the other structure. And when they become active, they can be stressed, they can affect your range of motion. And in itself, the ligaments actually help sort of protect the joints from being hyperflexed. So differential diagnosis of low back pain, this is sort of a list, and then I'll go specifically through some of examples with cases that I've encountered in the last, well, recently in the last year. More common is back strain. We have fractures, acute disc herniation, osteoarthritis, spinal stenosis, spondylolisthesis, ankylosing spondylitis, infection, malignancies, and rheumatologic and neurologic problems. The most common is a person who presents you with acute low back pain. And when you see them, as Dr. Kaufman had stressed, is, you know, you have to look at sort of the whole picture, you know, their age, where is their location of the pain, the quality of their pain, what are the aggravating or relieving factors of their pain, and what are some signs that you can pick up on examinations. And that helps you think about what the problem is. And the most common that you'll encounter in your practice is back strain or back sprain, and that's about 80%, even maybe 90% of the patients that you see. And they are the patients who don't necessarily have to come towards Mike and I, but can be managed you know, conservatively. And these patients are usually sort of the 20s to 40-year-olds. They come in with low back pain, some buttock pain, some posterior thigh ache or spasm. Sometimes increase with activities or bending over. And sometimes there's some local tenderness in the back and some limited spine motion. And most of the time that's because of some spasm. And this is very common. The other things, so that's about 90% of the patients you see. So all you have to really know is sort of the other 10% and how to differentiate that. So that's going to be easy for you. So the other 10% are composed, well, I'll just go through them. Fractures can be different type. There can be the traumatic, so it's easy for you to elicit a history, see if they fell, you know, motor vehicle accident. Then there's pathologic fractures and osteoporotic fractures. And of course, those are different age groups. And also, by history, you will know if somebody has had an underlying malignancy or cancer that they've been dealing with. And you keep that in the back of your head as you're thinking about a patient and treating them. For example, so I like to always bring cases just to sort of illustrate a point. So for this is an interesting case. It's a combination of problems in this MRI here. So it's a 64-year-old woman who was sent to me, initially told that she had a spine fracture, and that's why she was sent to see me. She slipped on ice about 6 months ago and started to have sharp pain initially, and then now it's more like a dull ache. But then on further questioning when I talked to her, she was saying, well, you know, the problem is really there's some back pain, but really it's just sort of every time she walks, you know, her symptoms, she starts to get shooting, radiating pain down her leg with even some numbness and tingling. So her problems, although she was sent to see me for a particular problem, which is on this MRI, as you can see, if we count up from the sacrum, which is here, the first disc separates the lumbar spine from the sacrum. This would then be L5, L4, 3, 2, 1. So she does have this L1 compression fracture. You see the wedging of the vertebral body, as Dr. Lee has shown you on plain X-ray. This is what it would look like in MR. But on examination, when I tested her, did a heel clump test, palpated her back, she actually had no pain up in that upper level. In fact, her complaints are sort of this neurogenic claudication type problem, which is pain that is elicited on standing and walking. Even short distance would elicit the problem, radiating down the back of the leg. It's better when she bends forward or sits down, and which is sort of this classic lumbar stenosis, which is what she had down here. So I ended up taking care of her lumbar stenosis problem and didn't do anything for the low back. Since it's older, it's no longer causing any pain. Pathologic fracture. This is a different woman. This is a 52-year-old woman with known multiple myeloma who presents with severe low back pain. There's no radiation to the pain. There's no bowel bladder dysfunction. And this is her this is her MRI. And she does have this T12 compression fracture. So at T12, if somebody had a fracture in the lumbar spine, it's important. But when you talk about thoracic spine fractures and even cervical, it puts me on a little edgy because you're talking about cord structure right behind those areas. So for me, an MRI is important for, let's say, somebody who has a fracture higher up who may have some fragment into the canal. So luckily in this case, she doesn't have any compression. It's quite tight, but she's not symptomatic. There's no bowel bladder issues. There's no lower extremity problems. And so in this case, I did just manage her non-surgically. The options are brace or no brace. It depends on her pain and what activity makes it worse. And there's a possibility that she may need some type of intervention like kyphoplasty, vertebroplasty, but it's only a specific case. And in this case, we just managed her in a brace. Other differential diagnosis and sort of that 10% we talked about is acute disc herniation. And they present in patients in their 30s and 50s. Usually the pain could have some radiating component. Low back radiates down the lower leg. It's a sharp, shooting, burning pain with sometimes some paresthesia in the leg. It usually decreases standing. That's interesting because patients always wonder why the disc or their disc herniation is more problematic when they sit down. And what I tell them is when you sit down, you sort of let go of your whole body's weight and you let it sort of sit on the weight of the disc. And that can make the disc push out a little bit more and hurt, be more painful. But when you stand, technically you should be engaging your core muscles. And because of that, you sort of brace the weight away from the disc. And that's why it's important to sort of listen to their history. And the other signs would be, as Dr. Kaufman said, positive straight leg raise, look for weakness, look for asymmetric reflexes. So here's a case with a younger patient, 28-year-old, with low back pain. Again, worse with sitting and activity. Initially, it didn't radiate anywhere, which is interesting. And she was actually managed nicely by a primary physician conservatively for a few months. And no MRI was done until more recently she started having some shooting pain down the left leg, and that prompted an MRI. And interestingly enough, she has one of the bigger disc herniation I've seen. And the interesting thing about this case is that it's mainly midline, and that explains why she never really had radiating pain down to the other side until, more recently started to aggravate the left side. And you can see it's slightly more narrow and slightly more to the left, but it's definitely a big midline disc herniation. So that's the difference in this case. And the other thing to sort of know about sort of these large midline discs is that they can actually cause some emergencies like cauda-equina syndrome. Here's another acute disc herniation case. It's a 30-year-old woman with complaints of low back pain radiating down the left buttock, so a little bit more classic, with numbness and tingle in the lateral aspect in the sole of the left foot, which sounds like S1 distribution. And what this patient has on the MRI is, it's very interesting. You don't actually see this very often. It's rare, but this is a disc herniation from the L5-S1 space that has extruded out of the interspace. So it's no longer within the annulus. And on the axial image, you can sort of barely see it. And it's interesting because extruded disc sort of has can be a different animal in terms of what type of treatment they may require. If the disc was up higher and extruded, it could actually float down and affect a different nerve root at the levels below it. And in fact, there's even some case report where extruded disc can be resorbed because the disc is sitting in an epidural environment which has some vascularity to it, and that can actually help them absorb the disc. So, it depends on how the patient presents, but this is definitely rare but interesting. So other differential diagnosis includes osteoarthritis and spinal stenosis. So we've gone to sort of the younger patient to a little older, but still very young, greater than 50. Usually their location of the pain is in the lower back to the lower leg, often bilateral. It's an achy pain, a shooting pain, sometimes pins and needles sensation. Again, increase with walking, especially with up and incline, and decrease with sitting. And this is sort of an interesting history because with spinal stenosis, what happens is when you're erect, the spinal canal actually narrows, and when you bend forward, it's when the spinal canal actually opens. And the other thing to know about how they present is that sometimes with a mild decrease in extension, they tend to keep themselves bent a little forward. So they'll say, you know, I've been walking sort of bent forward lately, and it's just, I've never done that before. And that's sort of a history that you wanna pick up as well. And of course, any weakness or any asymmetry in the reflexes is important. So I have this, there's a 45-year-old woman actually who presented with classic lumbar stenosis symptoms. I said they should be in their 50s, but this is a younger patient. And she has lumbar stenosis, classic and sort of classic clinical presentation, but in her case, her lumbar stenosis is not just sort of the classic impingement of the bony structures in the back and the disc from the front, but she actually has this malalignment called the spondylolisthesis, and that can cause the narrowing of the canal. And you can see this is quite tight. This should be nice and round and open. Clinical findings of lumbar stenosis. Again, leg pain, numbness, tingling, weakness. It increases with standing and walking. Usually they'll say that when they walk for short periods, they have to stop, maybe even sit down to get sort of their legs to work again. Or they'll mention that while they're shopping, it's actually not too bad because they can lean over their shopping cart and have no problem when they're shopping. It also sounds like vascular claudication. You know, those are the people who walk and their legs start to burn and hurt. And so how do you differentiate the two between neurogenic and vascular claudication? And the key thing is with vascular claudication, the cramping of the calves and the leg pain is brought on by ambulation, but it's just relief with just rest alone. But in the neurogenic type, you actually have to change your position and bend forward to get a relief of your symptom. And the cause of that and why this occurs is, again, there could be direct compression from the bony elements, the laminas, the facets being overgrown, the disc pushing from the front. It could be an indirect vascular insufficiency. Walking compromises the arterial supply, and therefore you get this fluctuation of the adequacy of the vascular supply to the cauda equina and leading to neurogenic claudication. And again, sitting and recumbency does reverse the lordosis and open up the canal. This leads to spondylolisthesis. Spondylolisthesis is interesting. It can present in any age. I mean, we see teenagers with spondylolisthesis, and so they'll have some back pain, some posterior thigh pain. They'll have some achiness, and sometimes that's all they'll present. Or let's say a teenager comes in and they say that their hamstring is tight. And that's sort of one key thing. This tight hamstring is sort of a phenomenon where if the spondylolisthesis, the alignment is so off, that you have a stretch on the hamstrings because the body's bent forward. Sometimes you can even see an exaggeration of the lumbar curve, and you can possibly palpate a step off. Other part of our differential diagnosis is to think about ankylosing spondylitis. Not as common in 15 to 40-year-old, and the key thing with ankylosing spondylitis is that they have a sacroiliac joint pain, as well as some lumbar pain. It's an achiness. They get up. There's some morning stiffness, and overall they have decreased mobility and decreased motion. And sometimes with the test of the sacroiliac joint, you can pick that up. Infection can cause acute low back pain. Again, this can occur at any age. They can present with just lumbar pain, or they can present with sacral pain. It can be sharp in nature or aching in nature, and it varies. And the key thing to think about infection and whether or not somebody has it is see if they have a fever. Is there any percussive tenderness? And do they have any neurologic abnormality or decreased motion? And of course, within infection is the abscess collection. Infections can just be diffuse, or it can actually form a mass, and that can cause problem such as compression and cauda equina. Here's a case of a 64-year-old female who presents with 2 days history of right hip and back pain. And her only sort of contributory medical problem is that she has type 2 diabetes. This is the sacrum, so this is the L5-S1 disc, and this is L5, L4, L3. So at the L3-4 disc, there's definitely some changes within the disc itself, some bright signal in the disc, and also some changes right behind it. So we actually sent her for a CT-guided biopsy and found that she had a Staph aureus infection. For somebody like that, the mainstay of treatment would be just antibiotics and follow her, especially if clinically she has no neurologic compromise. Towards the end of our differential diagnosis, malignancy is always sort of in the back of our head as well. It presents in patients usually much older, in their 50s, not much older, I have to take that back. It affects the bone, it's a dull ache, a throbbing pain, slowly progressive, and it can be worse with recumbency or coughing. And this is actually interesting because with neurologic tumors, one of the key things is that at night when they're lying down, their pain is increased. And that's because of sort of the pooling of the venous structure, and that actually can engorge the tumor and make it more symptomatic in terms of pressure. And with malignancy, you can also have some local tenderness or some other neurologic signs or a fever. This is different. I'm going to present this case, but it's certainly not sort of the malignancy that you guys would think of, breast cancer, METs, and things like that. This is somebody with a pneumoma. 33-year-old male with back pain at rest, pain that radiates down the left leg. He presented with some weakness, some difficulty voiding, and the reason why he had a whole back workup was he was actually involved in a motor vehicle accident. And after about a month or two of sort of the usual, muscle strain that should go away after a motor vehicle accident, he still had persistent symptoms and persistent pain, and that prompted an MRI of the lumbar spine. So on this MRI, you can see this is a T1 image, this is a T2, and the way you can tell is that the fluid is white on T2, and the fluid or the CSF space is dark. And you can see a shadow of a mass here, and again on the T2, and then when you give contrast to the study, you can see that the mass enhances. And here you need to also pick up in terms of where the spinal cord ends and where the conus is. So the conus ends here, and the tumor starts here. And I can pick up that here's the phylum terminality, and here's where the tumor starts. So that actually is one key to pick up what type of tumor this could be. And this is usually at the sort of conus region, it's usually a myxopapillary ependymoma. So he's certainly symptomatic. These are just some axial images showing how big this lesion is compared to the space he should have for his nerves. And yet, he wasn't paralyzed or anything, but he just had some leg pain, some numbness and tingling. So we actually took him to the OR and took out the lesion with just a 2 little level laminectomy. And you can see postoperatively the tumor is gone. And he did well. This is the postoperative CT showing the defect and what we do to do the surgery. We take them the lamina and the spinous process in order to get to the, open up the dura and take out the tumor. Another case of malignancy, this is a 52-year-old woman who I took care of about a year ago, diagnosed with breast cancer, who presented with increasing back pain and also some left leg numbness and tingling. She had more of a left L3 radiculopathy. And this is her MRI showing this lesion here within the vertebral body of L3. And on the axial, the reason why she has this left-sided symptom is she has involvement of that space right where the frame is, right where the L3 and L4 nerve root exits. And that's at L3. So we actually took care of her as well, did a posterior decompression and a fusion in her. And just to mention and to be thorough, neurologic disorders, tumors, schwannomas, ependymomas, and meningiomas will be part of a differential diagnosis. Perineural cysts we see sometimes, and even hematomas can occur. The emergencies that we should keep in mind after hearing all the differential diagnoses. Cauda-equina syndrome is an emergency. If somebody comes in, loss of bowel bladder, no feeling in the saddle region, then they definitely need some type of investigation. Other red herring I don't know much about, but dissecting aortic aneurysm can give you acute low back pain. And of course, anybody with worsening neurologic symptoms, intractable pain, resistant to conservative management should we should think twice and then sort of bring them to the attention of the practicing physician. Other emergency, here's an example of a woman I took care of, and she presented emergently with numbness in the saddle region, pain radiating down her leg, paresthesia in both legs entirely, and also some loss of bowel bladder function. And I did get a sexual history. She was having problems as well for a little while. But what acutely brought her in was actually she had a tumor that hemorrhaged in the tumor. I'm sorry I don't have an MRI of her lesion, but intraoperatively I'll be able to show you what we found. So she had a big hemorrhage that went all the way from L2-3 down to the sacrum of even S2. So I had to do a pretty wide opening to expose the dura. Once the dura was open, you can see, this is why they call this sort of the horse's tail. These are sort of the nerve roots. You see how they can look like that. And right off the bat, you'll see that there's some yellow discoloration to the nerve roots. And that's because there was a hemorrhage. And here is some of the hematoma. And right here is where her tumor is. So it was quite involved, and you can imagine all those nerve roots are quite irritated with hemorrhage and everything. And so postoperatively she did well, she recovered her function, but she still had, some sort of strange sensations in terms of her legs, because those nerve roots have been bathed in blood, and so it takes a while. And I bet you down the road she'll probably develop something called arachnoiditis, which is sort of this clumping of the nerve roots and things like that. And other emergencies would be sort of the patients who present with the epidural abscess. Again, unresponsive fevers, increased pain, neurologic deficits, and those are things that should sort of come to attention a little bit quicker. But as we stated, the main thing you'll see will be back sprain. The rest of the 10% you kind of want to keep in the back of your mind and think about those issues, and just make sure that you know your emergencies. And that's what we're here for. We're here to sort of see all your patients and help you figure out what to do with them. Thank you.